And while we think about financing, raising funding for the programs which are so close to our heart, I think it's also important not to forget that financing not always is the key binding constraint for programs to work. What comes to my mind is a story that I was just recently pulled into. I was asked to chair an evaluation of a maternal and child health program in a low-income country in the Middle East, North Africa. And this program had everything going for it. It had appropriate financing, it was public-private partnerships, it had the NGO sector deeply involved, sound assessments of just everything that you can think of went into the design of these programs. And yet, after 2 years of pilot operation, when we evaluated it, whether it's worth to continue, they were supposed to reach about 40,000 poor women. And in the end, they had reached 1,900. So something went terribly wrong, despite the fact that we had the financing lined up and despite the fact that we believed that everything had been put in order in terms of the assessments and analysis. So financing is important, but I think we should look at where linked to the financing are some of the binding constraints, why some of the programs that we are supporting in the end do not deliver to the degree that we wish for.
The challenge to donors is to find ways to live up to their commitments to development assistance, if necessary through innovative forms of finance, as reviewed by the High-Level Task Force on Innovative International Financing. And speakers in the audience may wish to pick up specific examples of these innovative finance mechanisms. But it's also critical that donors find ways to provide the continuing, coordinated and consistent support that is vital to rebuild health systems and invest in training health workers. Why, for example, should countries invest in greater training capacity if they don't know from 1 year to the next how much money they will have available to spend on health? The challenge to recipient governments is twofold. Firstly, to increase domestic resources to health and increase financial protection so that the poor are not further impoverished by healthcare costs. But secondly, recipient governments must strengthen the functioning of their health system. And this is absolutely not just a matter of money. More money will help, but governments must address problems of efficiency of resource use, health worker performance, drug supply systems, governance, and so on. And in thinking about health system strengthening, governments should also be prioritising research that can guide them in the best approaches to health system strengthening. As was found by the High-Level Task Force on Innovative International Finance, the evidence base for guiding countries on how best to improve service delivery and strengthen the health system, that evidence base is very weak. And then finally, the challenge to the private sector is to identify, in close collaboration with governments who are accountable for the health of their populations, to identify how the specific strengths and expertise of the private sector can best be deployed.
So one of the messages that I do have to say is that governments, finance ministries right across the world in different ways are becoming more businesslike about how they think about resource allocation. If health departments, if health ministries are wanting to communicate priorities, communicate effectively where resources need to be channeled, they need to be businesslike about that. That isn't done in the same way in different places. I think there's a long way to go yet in improving budget processes and budget decision-making. Certainly in South Africa, we've taken several steps backwards for many of the strides we've taken forwards, but bringing non-financial information into budget processes is part of the budget game everywhere in the world. And the conversations between health officials, health scientists, health advisors, and their Treasury counterparts need to be informed by better measurement, better information, better evidence, and that needs a lot of work.
So specifically, our bottom line is fewer children dying, fewer mothers dying. And we work in other areas too, so it may be the delta around how many kids can read now, how many will be able to read, but being very explicit about what we will accomplish, what the evidence is, are these realistic targets based on our evidence, and then putting in a system in which once we've decided what the highest value interventions are likely to be, of being willing to monitor and adapt as we go. If a company were to put a new product on the market and decide this was how it was going to approach its marketing, it would try promotions, it would try radio, it would try all sorts of interventions based on what should work in marketing. But then it would monitor. And when advertising wasn't producing any uptake, but promotions were, the strategy would shift. And we've got to do that in our field as well. We've got to either look and figure out, is our advertising not conveying the right message? Is it the advertising? Or is it not the best strategy or activity to get the target that we want, and reallocate resources and rethink our strategy? We can't just go with a tick list of activities blindly and measure at the end to see how we did.
When I was sitting as housing minister, I argued on water services that water was crucial to fight poverty. You know, 3 weeks later, I was sitting at the other side of the room, and I was health minister, and I was arguing that mother mortality and infant mortality was, the question to be resolved. And that has to do a lot with the political economy of how the budget is allocated. But now that I am out of the two positions, what I can tell you is that the problem we might be facing some of that here is that we tend to dissect reality. And that's a mistake. Even from the point of view of the people, it's not that they are facing infant mortality or mother mortality or water services, lack of water services, or any other health problem. They are facing poverty. And let me take this one step forward. It's not even poverty, because poverty is something that the market can resolve. They are facing what statistically is known as extreme poverty, but is really a different phenomenon in its nature. Extreme poverty, which is this social perfect storm, it's something which is meta-market. It's far beyond the market. It's not encompassed by market thinking, because by definition, the extremely poor are the excluded. It may be by gender, because of gender, by geography, by cultural basis. But this is a different phenomenon, and the only way to deal with that is government and government intervention. It's naive to believe that this can be solved by the market. I do believe that there is a big role for what we're discussing here in solving the problems of the poor, but this is a different animal.
One of the first lessons that we realized is that we invested a lot on training, and training of not only the clinical staff, but the management staff. We realized that there is a dearth of trained management, healthcare management people in the industry. So we have midwives, we have doctors, but who's going to manage? So there's a need to have a management, strong leadership team. If you look at a LifeSpring leadership team, it's very interesting. I'm not a doctor. In fact, before getting into what we call the babies business, where we produce babies, I was into contraceptive business, where I was trying to stop having babies to come in this world. Most of our people who work with us come from operational background. They have worked in factories, chartered accountants, but we also have a doctor in the team. There needs to be much more multidisciplinary approach to this. I believe there has to be investment on training. Second, we have to look at this challenge or the problem from a much more system approach. And there are different players or different elements that interact with each other.